I am Dr. Mohammad Amit. Today I am presenting castration-resistant prostate cancer. And my moderator is Dr. Mudassir Hussain. So, in the next 1 hour, our learning objectives are definition, pathophysiology, treatment option, and complications. So, definition of castration-resistant prostate cancer is disease progression despite androgen depression therapy and may present as either continuous rise in serum prostate-specific antigen level or appearance of a new metastasis. So, the criteria is to label castration-resistant. The testosterone level should be less than 15 nanogram per ml. Biochemical progression, which is 3 consecutive rise in PSA, 1 week apart, resulting in 250% increase over the nadir, with PSA more than 2 nanogram per ml, and progressive metastasis, the appearance of 2 or more than 2 new bone lesion, and progression despite cessation of androgen deprivation therapy. So, in the past, we used terms like hormonal refractory, androgen independent, and androgen resistant. Now we call castrate resistant prostate cancer. So, why does it happen? It is because of increased androgen production in the tumor, increased androgen receptor level, alterations in the androgen receptor, that mutation, and other pathway, non-androgen dependent. So why is it important? It signifies accelerated growth of the cancer, if not yet metastasized, then much greater likelihood of metastasis in near future. Now enter a time with very predictable time to death, that once we label it as a metastatic castration-resistant prostate cancer. So mechanism involve or androgen dependent, two type of mechanism are involved: androgen dependent and androgen independent mechanism. So in the first one, during androgen dependent progression, prostate prostate cancer cells depend primarily on the androgen receptor for growth and survival. When the androgen receptor is inactive, it is bound to heat shock protein in the cytoplasm of the prostate cell, like here. The androgen dihydrotestosterone bind to the androgen receptor, dissociating it from heat shock protein. The dihydrotestosterone bound androgen receptor translocates into the nucleus, dimerize, and binds to the androgen response element. Dihydrotestosterone is combined with the androgen receptors and take it from cytoplasm to the nucleus, and with the help of coactivator and androgen response elements, it further growth of the tumor cell.
So this is the normal pathway of how the androgens stimulate the growth of prostate. The dihydrotestosterone bind to androgen receptor, and the receptor goes into the nucleus, and then it activates lots of things. So when you do castration, you actually remove the dihydrotestosterone. So there is no stimulation of the androgen receptor, and therefore growth of the cells are inhibited. But with time, this lack of dihydrotestosterone is overcome by different mechanisms that we are going to talk, and because of that cancer become castrate resistant, right?
During androgen independent progression, prostate cancer relies on various cellular pathways, some involving the androgen receptor and other bypassing it. In the former type of pathway, a mutated androgen receptor may be activated by various agents. In addition, deregulated growth factors and cytokine can activate the androgen receptor. These are the legends and cytokine and growth factors. In the former type of pathway, a mutated androgen receptor may be activated by various agents. In addition, deregulated growth factor and cytokine can activate the androgen receptor, usually with the help of androgen co-activator. The androgen receptor may be amplified and therefore activated by reduced level of dihydrotestosterone. So, in the pathway that bypass the androgen receptor, the loss of PTEN reverse the inhibition of AKT pathway, permitting activated AKT to phosphorylated bed. This activation results in the release of BCL2, which eventually leads to cell survival. In addition, androgen independent cell may overexpress BCL2. Prostate cancer cells may develop neuroendocrine-like behavior. Neuroendocrine cells secrete neuropeptides that induce the growth of adjacent cell, and thus prostate cancer may survive therapeutic intervention. So, resistance mechanism can be divided into 6 groups. Number 1, increased expression of enzyme involved in steroid genesis. In CRPC patient, even castrated serum level of androgen are still sufficient for androgen receptor activation and able to maintain cancer cell survival. The intratumoral level of testosterone in CRPC patients are equal of those found in non-castrated patients. The source of these androgens is thought to be derived from the synthesis of androgen directly in prostate cancer cells due to an upregulation of the enzyme. And second is increased expression of androgen receptor. The activated androgen receptor pathway has been postulated as a result of genetic phenomena that promote increased sensitivity of androgen receptor. And third one is androgen receptor gene mutation and altered ligand specificity. While the androgen receptor are the main factors of the tumor growth and androgen receptor signaling, the presence of androgen receptor mutation leads to its activation by non-androgenic steroid molecules and anti-androgens. Downstream signaling, which is one of the most important mechanism, and the last one is bypass pathway. This induction of bypass pathway independent of androgen receptor is an important mechanism of castration resistance that can overcome apoptosis induced by androgen deprivation therapy. And the stem cells, prostatic cancer stem cells are real but and undifferentiated cells that do not express androgen receptor on their surface, being independent of androgen to survive. These cells can be responsible for maintaining tumor growth and development because they are able to survive under androgen deprivation therapy. So these are the mechanism. Now coming to the classification, we can classify castration-resistant cancer into metastatic and non-metastatic. Non-metastatic CRPC are with rising PSA without any mets, and MCRPC metastatic disease, bone or soft tissue visible on imaging. Risk factor, CRPC risk feature for poor survival is low HB, elevated LDH, elevated alkaline phosphatase, poor ECOG status, visceral, especially liver mets, narcotic use for pain. So, clinical consideration, a complete disease evaluation is required to estimate the outcome and to make therapeutic decision. Critical baseline components are extent of the disease, mood and site of the progression, rising PSA level alone, new bone metastasis, visceral and nodal metastasis, presence or absence of symptoms, response and compliance of peripheral endocrine treatment. Initial strategy for non-MCRPC is unclear, as no radiotherapy has shown any survival advantage in the setting of no radiologically measurable disease. Continuing medical castration is recommended. Verify castrate level, and if not less than 15 nanograms, then alternative luteinizing hormone, raising hormone agonist or antagonist or architectomy. So define treatment objective for patient palliative versus prolonging survival. The current treatment options for patients with castrate-resistant prostate cancer can be divided into different group. That is, discontinuation of the anti-androgen, secondary hormonal therapies, bone-targeted therapies, chemotherapy, vaccine-based immunotherapy, radiotherapy, and novel agents. So, androgen deprivation therapy in castration resistant. So these are the flow chart. Continue androgen suppression, that is luteinizing hormone releasing hormone agonist or gonadotrophic releasing hormone antagonist. Change to different anti-androgen like flutamide to beclutamide that reduce PSA to 61% in some studies. And then ketoconazole with steroid. Sustained reduction for 3 to 8 months, PSA decrease more than 50%. And aminoglutamide with steroid, 250 mg per oral, 6 hourly. Inhibit cytochrome P450. And the last one is diethyl stilbestrol, that PSA reduction is in 43%. And then chemotherapy. So novel androgen receptor directed approaches are CYP17 inhibitor, that is ABIRATERONE, and other agents, and androgen receptor molecule, which is enzalutamide. So now I will explain. ABIRATERONE, we will give 4 tablets per day with prednisolone 5 mg 12 hourly. Take on empty stomach at least 1 hour before or 2 hours after meal. Mechanism of action, because basically it inhibit ABIRATERONE CYP70, which have enzymatic activity of both 17 alpha hydroxylase and 770 lyase. In this way, it target the biosynthesis and enzalutamide. It give it a dose of 160 mg per oral per day, may administer with or without food. And mechanism of action of enzalutamide is enzalutamide inhibit androgen receptor testosterone binding with higher affinity than glutamide. Enzalutamide receptor inhibits block the activational changes induced by androgen receptor testosterone binding. And enzalutamide inhibit androgen receptor testosterone nuclear translocation and DNA transcription. Basically, it is androgen receptor modulation drug. So non-hormonal therapy, that is chemotherapy. In this group, we have Docetaxel, Cabazitaxel, and Mitoxantrone. So docetaxel is the standard first-line chemotherapy for the metastatic CRPC. It prolongs progression-free and overall survival. It relieves pain and improves quality of life. Docetaxel is believed to have a twofold mechanism of anti-neoplastic activity. Number one is inhibition of the microtubular depolymerization, and number two is attenuation of the effect of BCL2 and BCLXL gene expression. So in this way, it produces apoptosis of the tumor cells. So initial dose is a single agent, 75 mg per meter square, given every 3 weeks. And the common side effect is neutropenia, and other side effects are myelosuppression, fatigue, peripheral edema, neurotoxicity, hyperlacrimation, and nil dystrophy. Cabazitaxel has emerged as a second-line chemotherapy option for patients with mCRPC who have had progressive disease during or after docetaxel therapy. But it is differ from docetaxel because of its poor affinity for pig glycoprotein, the adenosine triphosphate dependent drug efflux pump. So this is the dose, and the common side effects are diarrhea, fatigue, nausea, and hypersensitivity. And the last one is Mitoxantrone. Although it does not prolong survival, but it has been approved to palliate symptoms associated with metastatic disease, and it is often used in patients who have previously received docetaxel and or cabazitaxel, or in those who would not tolerate these agents. So this is vaccines. Spilacil T is an active cellular immunotherapy agent. It activated in vitro by a recombinant fusion protein, that is prostatic acid phosphatase fused to granulocyte macrophages colony stimulating factors. And the dose is 3 doses at approximately 2 weeks interval. How it is prepared? That dendritic cell of patient own blood is taken by leukapheresis and cultured in ex vivo with prostate acid phosphatase and GM-CSF. And then this is taken antigen taken up and presented by antigen presenting cells. And in this form, this activated T cells are reinfused to human own body, and in this way encouraging that activate T cells, and the T cell proliferation occur, and the T cell attach to cancer cells. So this is the mechanism of vaccine. So coming to the palliative management, pain and epidural cord compression. Patient with back pain and a history of bone metastasis should be evaluated for epidural cord compression. The clinical syndrome often induces at least one of the following signs and symptoms: back pain, focal neurological deficit, that is leg weakness, sensory level, or change in bladder or bowel control. Initial management of suspected cord compression include immediate MRI of the spine and initiation of the high-dose intravenous corticosteroid therapy. Definitive treatment should be include radiation therapy, surgical decompression, or both. So, in both bone targeting approaches, for bone pain, you use radiotherapy, radium 223, and for vertebral collapse and deformity, we use bisphosphonate, and for pathological fracture cementation, and spinal cord for spinal cord compression is decompression or corticosteroid. First we use corticosteroid, given corticosteroid, then so bisphosphonate is inhibit osteoclastic mediated bone resorption, highly effective in reduced bone pain. Zoledronic acid is a bisphosphonate which is given in 4 mg, but it causes side effect of this is jaw necrosis. But bisphosphonate has no survival benefit. It is only given for in pain. So how it work? Bisphosphonate inhibit osteoclast activity and promote osteoclast apoptosis. Bisphosphonate may modulate signaling from osteoblast to osteoclast. Bisphosphonate are released locally during bone resorption and concentrated under osteoclast. So, and the second one is zoledronic acid, which is a hyperglycemia of, it is first given in hyperglycemia of malignancy, multiple myeloma, documented bone metastasis from solid tumor. DENOSUMAB, fully human monoclonal antibodies. It is against receptor activation of the nuclear factor Kb ligands and mediator of osteoclast formation, function, and survival. It increases bone metastasis free survival. So how it work? Basically, denosumab here it combined with this wrinkle cells and protect the osteoclast activity, occupy this space. So radiotherapy, radium 223 is a novel alpha emitting radiopharmaceutical that the FDA has approved for the treatment of symptomatic bone metastasis in CRPC patient without visceral metastasis or bulky lymph node disease. The recommended dose is 50 per kg intravenously every 4 weeks for a total of 6 cycles. So this is a different which we already explained. It enzalutamide basically. Enzalutamide basically modulate androgen receptor and work on the prostate cancer cells directly. And acetate is also work on prostate cancer cells. Basically, these drugs are work on direct prostate cancer cells, and these one radiotherapy, these are work on bone. This is the best. Okay. So European guideline are ensure that testosterone level are confirmed to be less than 15 nanogram per deciliter before diagnosis castration-resistant prostate cancer. Manage and treat patient with metastatic CRPC in a multidisciplinary team. Treat patients with metastatic CRPC with life-prolonging agent. Base the choice of first-line treatment on the performance status, symptom comorbidities, and location and extent of the disease, patient preference, and on the previous treatment for hormone-sensitive metastasis prostate cancer. Thank you.